Hi, my name is Dr. Brendan O'Shea. I'm a GP. I'm at the Bridge Medical Centre in Newbridge, County Kildare, where this study was carried out. Thanks very much for being interested in these really important topics, stigma, obesity stigma, and self-stigma. This study looks at these topics in the context of general practice. What are they and what can we do about them? I'd like to enormously thank my collaborators, Geraldine Wade, who's using this project as part of her MSc, who's a clinical psychologist, and then Nadine Ferris-France, who needs no introduction in the Irish Global Health Network, and who also works with Beyond Stigma. So just some basic concepts. Stigma is the unjust assignment of negative values by a majority in a community to a minority, usually on the basis of things like religion, ethnicity, race, gender, or physical characteristics. Stigma can be delivered on the basis of almost anything. Self-stigma is where the individual who's the subject of the stigma begins to believe and to accept the negative attribution. I'm overweight, I could never be attractive. I'm overweight, I couldn't be effective. I must be lazy. I'm depressed, I can't be successful. For a long time now in mainstream medicine, we've understood that people who are significantly depressed will do far less likely with any medical condition that they have. And more recently, there's a huge understanding of the importance of stigma and self-stigma in many conditions, and especially including obesity. Obesity is a critically important driver of ill health in both affluent and in deprived societies. So again, we feel that this is an important area to move on, and we're looking to see what we can do with it in primary care with people who are suffering from obesity, overweight, and particularly who are self-stigmatized by it. Stigma is when you think negative things about me because I'm overweight. Discrimination is when the greater society do negative things about me because I'm overweight. Self-stigma is when I think or do negative things to myself or opt out of things because I feel worthless and because of my overweight. And the loss of agency is critically important. Our big question: is it feasible, acceptable, and useful to consider the use of inquiry-based stress reduction in the GP setting to address weight-related self-stigma among people who are overweight? The objectives of the study: we wanted to equip participants with self-inquiry skills to reduce self-stigma or to eliminate it. We wanted ourselves as a group, both the investigators and the participants, to gain a deeper shared understanding of weight-related stigma. We wanted to look specifically at the feasibility and acceptability of a 7-week course using inquiry-based stress reduction in relation to weight-related self-stigma. Can we do this in general practice? Will this work? Obesity is a very complex phenomenon. Many things drive it. So also we can understand intuitively that the solutions will be many and complex. And certainly you can have surgery, you can have medication, you can have talking therapy, you can have social support, you can have changes to society. We're particularly looking at a particular area of talking therapy and seeing if that can make a difference, delivered in general practice, which is the medicine of the community. It's close, it's accessible to people. Sampling: this was a 3-GP practice. We set up a convenient sample. We intended to recruit and complete the process with 15 people, preferably clinically stable adults, invitation from their own GP, BMI of greater than 30, process of invitation and enrollment, and then intervention preceded by a pre and a post evaluation. So the format for people were approached by their GP. We're doing this piece of research. It's particularly relevant to people who are overweight. Would you have an interest in it? Explanation. So people who expressed an interest, they had an introductory session. They then had 6 modules. Then there were also 3 additional one-on-one individual sessions with a facilitator. Some of the people in the group attended with their partner. So there were some additional partner sessions reflecting the complexity of dynamics when you and your partner are doing something together. There was an online support forum for people to type in comments and get feedback. There was additional reading around the sessions, and people were given homework tasks, if you like, to develop a practice of self-inquiry between the sessions. So it was a purposefully selected convenient sample of people with obesity attending a 3GP practice, obesity defined as a BMI of greater than 30. People were invited and informed on the scope and purpose of the study. We obtained informed written consent and ethical approval was obtained. We inquired at the outset, when would best suit you to actually have these sessions? Would you like to do it live or on Zoom? This was conducted during the pandemic, so people opted for Zoom, and people opted generally for a Saturday morning session. Outcomes measured pre and post included BMI, weight self-stigma questionnaire, BEX, and the weight bias internalization scale. 7-week process, and the sessions included a session on self-stigma, judgments and limitations, prejudice and loss, me, my body and my weight, shame and guilt, communication and the meaning of overweight, who I truly am and who I can be. And then in addition to these main modules, there were, as I've mentioned, some separate individual sessions. Just a note on inquiry-based stress reduction, and many of us in the audience will have some understanding of this, previously known as the work of Byron Katie. It really is a technique for managing our distressing thoughts. It's a learned technique, it's a transferable skill, and intuitively the feeling is that it would be particularly relevant to people who are struggling with the burdens associated with overweight and obesity. At the heart of it is a technique to identify the most distressing thoughts that you have about the topic, in this case obesity, and to submit those thoughts to a process of inquiry-based stress reduction alone, on your own, with a facilitator, or in this instance with a group. And a group selected with a common identity. We're all patients of this practice. It's been explained to us by our doctors and by the psychologist in the practice, who is Geraldine Wade. So you look at each of the thoughts and you ask these great questions. Is this thought true? Can you absolutely know that it's true? How do you react? What happens when you have this thought, when you believe it? Who would you be without the thought if you could let the thought float away? And then there's the exercise of the turnarounds, to turn the thought around. So this is the technique that ran through each of the sessions. The feedback, we've recorded commentary from the participants. We have some measurements from the scales and BMI, and then we have our own reflections as a practice team, and particularly the project team, in terms of how this played out in practice. And our outcomes especially were feasibility and acceptability. We certainly had the impression that people who followed through with it, and 11 completed the process, it absorbed huge energy from them and very significant engagement and buy-in. And it's to some extent typified in this quote from one of the participants. It was interesting to see what we thought people might be worried about as the project team, and what the participants were actually worried about. And there were two quite different things. The group of participants, this was a key thought. I need to stop eating and I need to get out of this stop eating diet cycle. And again, in several of the sessions, the reflection was run. How does this thought make you feel? Who would you be without this thought? With respect to the study, 22 people were invited. 8 decided this wasn't for them for a variety of reasons. Some people felt it could be distressing. A lot of people felt they were too busy at the time. And looking at the profile of participants, they were largely young adults and middle-agers. 3 dropped out during the program, 1 because of an intercurrent illness, 1 because they felt that it wasn't relevant to their process, and 1 because they found it too distressing and upsetting. What did we learn? Intense shame and guilt were the major emotions to surface among the participants. And this is important because often when you talk to nurses or doctors or physiotherapists or psychologists, and particularly doctors, when you are consulting with somebody who is suffering from serious spectrum overweight, what do you worry about? We often worry about therapeutic impotence. There's nothing that we can do about this. We often worry about the medical risk, the dreadful things that can happen to people with serious spectrum overweight from a medical perspective. We often get obsessed about the numbers, especially the number on the weighing scales, but also the blood pressure number, also the diabetic number. So that's what we're concerned about. But the people that we're supposed to be caring for have an intense feeling of shame and guilt. So there's a cognitive dissonance there. Some other takeaways: weight loss attempts are absolutely meaningless without self-love and self-compassion. How good are we in the healthcare system around self-love and self-compassion in busy hospitals and GP practices? Many were wary of engaging with this due to anxiety about over talking about the topic. All of them felt that their weight was their fault and they had no control. And with the improvements in our scientific understanding around overweight and the pathogenesis of obesity, we know that nothing could be further from the truth. Another huge cognitive dissonance between what we as healthcare professionals feel and are concerned about and what these people feel and experience on a daily basis. We understood that it became difficult for people to keep up with the sessions because several of them had significant intercurrent illnesses along the way. So patients agonize about their weight, but healthcare professionals agonize about medical risk and complexity. We thought these were useful insights and delighted to share them with you. We learned that there was a huge and unexpected comfort felt by the participants in the group. They got to know each other well, and because they all came from the same practice, some of them kind of knew each other from the waiting room. Everybody's story was amazingly different. And again, our professionalized thinking is these are people with obesity. They can somehow be pigeonholed, which is terrible. Maybe I hope we can be forgiven for that, and I hope we can rapidly move on. The concerns that the participants had were generally around what others thought of them, not about medical risk. We learned that none of the participants' major concerns were health concerns. We are very worried about missing diagnoses, about difficult diagnoses, about diabetic complications. That's not what they're concerned about. Their main concerns were based around their feelings of self-stigma and the stigma they felt was attaching to being obese, the unfairness of it, the injustice, and the chronicity and the overbearing nature of it. Hard outcomes: we weren't trying to reduce weight over 7 weeks, but there was a tiny reduction in weight, completely not statistically significant, but people didn't gain weight. There were improvements in the depression inventory scale and to a lesser extent, the weight self-stigmatizing questionnaire. The impression was that it was absolutely acceptable to those who felt it was right for them. And we were glad about our process of information giving beforehand so that people could make their mind up whether to participate or not. And for 3 dropping out during the intervention, that was, we felt, a reasonable level of attrition. Of course, like all projects, we need to do further analysis of the data. This is a work in progress and is reported as such. And we're very excited about next steps. We certainly feel that general practice is a very good setting to bring in inquiry-based stress reduction. And of course, we are already thinking that there are a whole lot of areas that inquiry-based stress reduction could be considered in the general practice setting. This was the profile of our group. And as you can see, these were people with very serious spectrum overweight. And as I said, they were young adults or largely middle-agers. There were 3 men, and within the group, we made it across the finish line, which we were really pleased about because talking therapy traditionally seems to be more difficult for men to engage in. So well done to the guys, and well, thanks to everybody for really participating in an absolutely fantastic group. We would like to acknowledge their participation most of everything. We would like to acknowledge the expertise of the facilitators and particularly Nadine in relation to Beyond Stigma. I would like to thank our practice team at the Bridge Medical Centre, colleagues at the Department of Public Health and Primary Care at Trinity. We're very keen to get your observations or queries or comments in relation to this study. We really hope that you enjoyed it and we really hope it's of interest. Thank you for listening.